from adult topic, now we move on to children. The topic is hematuria in children. To chair the talk, I invite Professor Dr. Lalitha Kailas, Professor of Pediatrics, former Professor of Pediatric SAT, and now the Principal of Sri Gogula Medical College, to the chair.
A very good morning to one and all. At the outset, let me thank the organizers for inviting me to the chair for this session. The session is hematuria in children. I think that's not a very rare topic or rare event for a pediatrician in the OPD. Even the presence of 1 ml of blood in the urine can cause a significant reddish discoloration, and which causes significant anxiety to the parents as well as the patients alike. Though we know that majority of the cases of hematuria are benign, and especially the microscopic hematuria, which can be very transient, on one hand, on the other hand, we can have certain significant underlying renal pathologies, or even as a part of systemic illness also, we can have hematuria. So the onus is on us pediatricians to evaluate these children and decide on who are all require detailed investigations, immediate investigations and treatment, or who are all may need just a follow-up and reassuring them. So for that, we need to have an algorithmic approach. For that, I think Dr. Radhakrishnan is going to be the speaker. Radhika, she's the Associate Professor, Department of Pediatric Nephrology, SAT Hospital, Government Medical College, Trivandrum. I think after her MD in Pediatrics, she did her DM from the prestigious institution at the CMC Vellore. I know her as a junior colleague when I was in the Department of Pediatrics in the SAT Hospital. In addition to her academic brilliance, I think she's a very friendly and approachable person, and a very popular speaker in many of the platforms of the pediatric nephrology as well. I think the rest of the achievements you can read for want of time. I invite Dr. Radhika for her deliberation on hematuria in children. Over to you, Radhika.
Thank you, madam, my teacher. It's very nice to hear such pleasant words from you. So let's go straight to the topic. It is hematuria in children. So how do we define hematuria? It can be macroscopic or microscopic. Macroscopic just means there is gross blood in urine that everyone can see. Microscopic means there are more than 5 RBCs which are seen under the microscope. There's also another term known as persistent hematuria, which means if you see 2 out of 3 urine analysis done over a period of 2 to 3 weeks, it has hematuria. So this is a serious illness and requires further evaluation. So this is a very common scenario for every practitioner, whether a pediatrician or a physician or a general practitioner. A patient comes to your OPD complaining that the urine is reddish in color, or the mother says that the child's urine is reddish in color. So what is the first step to do? Of course, the first step is to keep calm and follow the rules. Why should we keep calm? Because already the parents are very worried that the child is passing a reddish urine, and it doesn't help us if we are also worried. So we just have to act cool and follow the rules. So let's see what the rules are. So the first rule, or rule number 1, is that all red is not actually blood. That simply means that a reddish urine does not always mean blood in urine. So how do we know that if it is really blood? We can always do a urine dipstick, which in addition to detecting blood, it will detect hemoglobin, myoglobin, and also it has the additional advantage of detecting protein. Next step is to do a urine analysis, which is definitive for the presence of RBCs. It means we centrifuge urine, take out the supernatant, and put it under the microscope and see. Of course, we don't do it personally, but the lab can give you the report. So there can be different possibilities. We can have a urine dipstick positive, but there are no RBCs in urine microscopy. That means there is some amount of blood, but it is not RBCs. So that it means it is either hemoglobinuria or myoglobinuria. To differentiate, we can actually centrifuge a fresh urine sample and look at the color of the supernatant. In hematuria, the supernatant will be cloudy red or dark brown with an RBC deposits in the bottom. Whereas if it is hemoglobin or myoglobinuria, the supernatant fluid will be clear pink and there will be no deposits. And when we add ammonium sulfate to the urine, if it clears, it is hemoglobinuria, and if it persists, it is myoglobinuria. So there are 2 things. You centrifuge, look at the color of the supernatant and see if there is a deposit. And if you have a colored supernatant, you add ammonium sulfate and see. Then you can have a condition where both dipstick is negative, the microscopy is negative, but still the urine is red in color. So what does that mean? That means there are agents which can color the urine. Other agents like red or pink urine can be seen with urates, drugs like chloroquine, fensopyridine, just eating lots of beetroots or red dyes in food, some food colors, porphyrins. Or sometimes an orange color or dark yellow colored urine can also be construed as reddish urine, which can happen with a very concentrated urine, which can happen normally after exercise or not enough water. Rifampicin, pyridium. They can be dark brown or black colored, like with bile pigments, methemoglobinemia, and homogenesic acid. Next rule. Whenever you see hematuria, don't always blame the kidneys. There could be other causes. Like the causes could be from the upper urinary tract, which is usually that is the kidneys. But cause could be also in the lower urinary tract, like in the pelvis, ureter, bladder, or the urethra. So how do we approach? How do we know that it is a glomerular hematuria or whether it is a non-glomerular or a lower urinary tract bleeding? In glomerular bleeding, the color is usually characteristically said as brown or cola colored. It is not bright red, which is seen in lower tract bleeding. And in glomerular bleeding, the bleeding will be uniform, like the whole urine will have the same color. There will be no clots. And if you have microscopy, you can see dysmorphic RBCs, RBC casts. And usually the urine albumin will show some proteinuria also. Albumin will be like 1+2, anywhere like 4+. The patient will have edema, oliguria, and hypertension. All of them are not necessary, but all this can be associated with glomerular bleeding. Whereas in a lower tract bleeding, as I said, the urine is bright red in color, but it is non-uniform and clots may be present. They can also have terminal gross hematuria. They can have other symptoms like irritating voiding symptoms, strangury, and under the microscope, all the RBCs looks the same, which are known as eumorphic RBCs, and usually they are not associated with proteinuria. To know where the lower urinary tract bleeding is coming from, you can have a 3-tube test in which you ask the patient to pass urine and collect the urine in 3 different tubes. And then you check the 3 tubes. So if the bleeding is more in the first tube, it indicates the bleeding is from the urethra. If it is more in the second tube, it doesn't help you. It can be anywhere from the tract. Whereas if it is from the hematuria is more in the third tube, it indicates that the trigone of the bladder is the source of bleeding. Again, glomerular hematuria need not be an isolated kidney disease. It could be like an IgA nephropathy, Alport syndrome, or a post-infectious glomerular nephritis. It could also be a part of a multi-system disease like SLE, Henoch-Schönlein purpura, Wegener syndrome, or other vasculitis. Extraglomerular hematuria, the upper urinary tract can be involved with severe infections like acute pyelonephritis, drugs causing tubular necrosis or toxins like snake bites causing tubular necrosis, again severe UTI or some drugs causing papillary necrosis, stones, thrombosis, malformations, etc. From the lower urinary tract, it again can be an infection of the bladder called as cystitis or urethritis, then stones, trauma, bleeding disorders, all can cause lower urinary tract bleeding. Rule number 3, listen to the story. This is very important in every branch of medicine, probably more so in nephrology. We get lots of clues from the history itself on the cause of bleeding. If there is a history of recent upper respiratory tract infection, it could indicate an IgA nephropathy. Or if there's a recent sore throat, like around 2 weeks back, usually we think of post-infectious glomerular nephritis first. There can be joint rash, abdominal pain, other rashes, joint pains, malar rashes and other rashes in vasculitis, SLE, Henoch-Schönlein purpura. Sometimes this is a recurrent history. A recurrent history can indicate IgA nephropathy, Alport syndrome, or rarely, which is very rare, I won't go to that. So dysuria frequency, suprapubic or flank pain can be seen in urinary tract infections, pyelonephritis or stones. Recent treatment with NSAIDs can indicate interstitial nephritis. Trauma can be cause of renal contusions leading to hematuria. Again, a history of recurrent hematuria is very important. This is because when we have recurrent hematuria, almost always it is pathological, and we have to think of isolated renal diseases as well as multi-system diseases. Rule number 4, family history is very important. So what is the family history that we ask for? History of hematuria again in family members. Hearing loss, because it could indicate Alport syndrome. Presence of hypertension, kidney stones, renal diseases, renal cystic diseases, hemophilia, sickle cell disease or trait. History of anyone who had dialysis or transplantation in the family. All this can indicate a familial and a more serious cause for hematuria. So hearing defects and visual defects are seen in Alport syndrome. Microscopic hematuria can be seen in benign familial hematuria, Alport, hypercalciuria. Renal insufficiency dialysis can indicate a chronic kidney disease like in Alport syndrome or polycystic kidney disease. Renal stones can be hereditary like with hypercalciuria and oxaluria. Rule number 5, clinical examination always matters. Hypertension and target organ damage like papilledema, retinopathy and LVH should always be looked for. If blood pressure is normal and urine is adequate, it is unlikely that it requires immediate treatment. I'm not saying it doesn't require immediate evaluation, but it doesn't probably require immediate treatment. But if blood pressure is elevated, you require a more intensive diagnostic evaluation and treatment. So high blood pressure can be non-specific of any renal disease. Edema can indicate diseases with proteinuria or with renal failure. Petechiae, purpura and rash can indicate HSP, SLE and vasculitis. Costovertebral angle pain indicates UTI. Pallor indicates anemia, SLE or HUS, and an abdominal mass indicates either a tumor or polycystic kidney disease. Rule number 6, diagnosis can be made in the labs. So we said we'll do the urine analysis, a dipstick and a microscopy. We also look at the renal function, electrolytes, anemia, and a renal ultrasound. And this is one of the common findings that we get. It's an RBC cast, which is seen in glomerular diseases. Dysmorphic RBCs again in glomerular diseases. Imaging, usually we start with an ultrasound, but it can mix some stones. Plain X-ray is rarely done, only when we suspect stone disease. An MCU when you suspect a bladder pathology or urinary tract infections. CT scan when we think of trauma, stones or malignancy. Rule number 6, a very important investigation who is our friend in glomerular hematuria is C3. So based on C3, and if you have a glomerular nephritis, we actually can classify them. If you see a low C3 GN, it either indicates a post-streptococcal glomerular nephritis or lupus nephritis most commonly, whereas a normal C3 is usually associated with an IgA nephropathy or vasculitis. Rule number 7, rare causes do occur but should not be forgotten. So we have some very rare causes of hematuria like nutcracker syndrome, in which the renal vein get compressed, sickle cell disease, never present, especially in the present situation, forget to ask for history of abuse or insertion of a vaginal foreign body. There can be something known as cyclical hematuria in females, loin pain hematuria syndrome, and transient hematurias. And if still in doubt, we can't find a cause, do a renal biopsy. So indications of renal biopsy would be if you think that it is not a simple hematuria and it is a glomerular hematuria, usually we do a biopsy. It can be present in indications at the presentation itself or when you think that this hematuria is not resolving. The rule number 9 is unfortunately that we cannot diagnose everything. So in spite of our intensive investigations, there would be some cases of hematuria which cannot be attributed to any cause. These patients have to be kept under surveillance. We have to look whether they are developing proteinuria, decreased renal function or hypertension. So this is what we have just said in a nutshell. When you have macroscopic hematuria with RBCs, without RBCs, if it is with proteinuria, it is glomerular. Without proteinuria, usually extraglomerular. I'll just end with some questions. So this is a child who had a gross hematuria following an upper respiratory infection, and C3 is normal. So when you have C3 normal in a gross hematuria child, usually the first diagnosis that comes to our mind is IgA nephropathy. This child was in our OPD 2 weeks back. Mom is calling now and saying that his urine looks like Coca-Cola. So you can see that this child is having a skin infection. So probably this is secondary to post-streptococcal, acute post-streptococcal glomerulonephritis, which is probably the most common cause that we see. This is a 3-year-old child with sudden onset hematuria but cleared spontaneously in a day. Here the family history comes in. His father has history of kidney stones. So obviously we think of renal stone disease first. A 3-year-old child with diarrhea later develops a rash, abdominal pain, and hematuria, and we have pallor and purpura. And here the peripheral smear is very important and clinches the diagnosis. It shows hemolysis and schistocytes, so this is a case of hemolytic uremic syndrome. Again, a lady with a malar rash. So basically, this is a SLE nephritis. And this is my last one. It's 11 p.m. at night, and we are the pediatric duty MO. MCH Ortho has just consulted on one of their patients. So you walk to MCH at almost midnight and see that the patient is in a cast because he was in a car crash 2 weeks back. And she's currently in a full body cast, and that there is nothing else in examination. So what is the one test that we should order? It is basically to look for a calcium creatinine ratio, because when the patient is immobilized, he's likely to have hypercalciuria, and that can lead to hematuria. Thank you.
Thank you, Radhika, for that excellent focused talk, which gives an insight, excellent insight into the topic. Just let me add one thing. Another important, it's not very common cause is Munchausen by proxy. Yes. I still remember we had one case where a child is admitted with hematuria, and we could not identify or recognize any cause of hematuria even after despite all investigation, including a cystoscopy, and finally, after careful observation, we could make out the diagnosis that the mother was doing all this for that child because she wants to stay in the hospital, does not want to go home.
To add to that, madam, we actually have biopsied even a Munchausen by proxy.
Yeah, right. So that is another important cause. Now the topic is open for discussion. If there are any. So usually it is oxalate stones, calcium oxalate stones, and it is very common. Even without family history, we get lots of kids, at least 4 to 5 patients, new patients in an OPD come to us because of stones. It's almost, and when we do a 24-hour estimation, most of them have a 24-hour oxalate excretion above normal. And it is not genetic because we have sent genetic study for many of the patients, and most of it has turned negative. Probably it is related more to the dietary habits, the high salt intake and the high oxalate diets that we are getting. Yes, the tumors I already mentioned. Okay, if there are no more questions, I think we'll wind the session. Once again, I thank the speaker as well as the audience for the patient listening. Thank you.